Thank you very much. I'm very happy to present Dr. Helmut Puererfellner from Linz, Austria, who will speak about the role of minimally invasive implantable cardiac monitors in arrhythmia diagnosis and management. Thank you very much for coming.
Thank you. Ladies and gentlemen, it's a pleasure to be here, and I have to thank Medtronic for the invitation. My time is limited, and so let's start with the role of minimally invasive ICMs in arrhythmia diagnosis and management. The outline of my talk is to talk about current indications, the REVEAL link device, the ongoing study, and maybe on improved, thank you, AF detection algorithms if there is some time. I'll look at my watch. The indications for the use of diagnostic, implantable, and external ECG loop recorders have been updated recently. Well, however, it's now 5 years ago in Europace, and it was done by Michele Brignole, and Panos Vardas is with us, who was co-chairing this paper. There are established indications for the management, the diagnosis and treatment of transient loss of consciousness of syncope. And there are some key points that clinical evaluation is enough to establish a likely mechanism of syncope in the majority of patients. You have to exclude high-risk patients who need an ICD, for example, not to lose time or lose the patient. Be aware that there is some pre-test selection of the patients influencing the subsequent findings. Include patients with a high probability because they have recurrent syncope in a reasonable time period, so it does not make sense to use such a loop recorder in a patient having one syncopal event every 5 years. And so it's unpredictable, and you have to be prepared to wait for a substantial time. And the ideal goal should be to have a correlation between symptom and ECG. So what is clear at the moment is that if you have a patient with unexplained syncope and you consider some arrhythmic event, it makes sense to use this device early on. Also with unexplained palpitations, there are in neurology some difficult cases of epilepsy which might be interesting, and some unexplained falls. However, the field is evolving. And the next part that has been covered there 5 years ago is the non-established indications. It's atrial fibrillation. And you know, as a key point, that there is a poor correlation in your patients between atrial fibrillation on the ECG and symptoms. So many patients have symptoms but don't have AF, and vice versa. We know that. And especially in AF ablation, it's a horror. There are two main potential reasons for accurate arrhythmia monitoring in clinical practice to determine the efficacy of a rhythm control therapy, especially in ablation, and in rhythm control trials when freedom from AF is the outcome parameter. AF, as we know, is significantly underdetected by intermittent monitoring systems. So if you take a whole ECG every 3 months or every 6 months, even if you do it 2 days in a row or even 7 days in a row, you will miss a lot of AF. We know that. And of course that influences the success rate. You might think you're successful, but however, there is still AF going on. So continuous monitoring is clearly better for these arrhythmias, especially if you use the implantable devices. However, technological improvements are needed, because if you have already implanted such system in AF, you might have discovered that the specificity of these systems is not that high. So you get a lot of false positive events, and it's a lot of work to look and review all the episodes. So that's the problem. When do I, in my country, in my hospital, use an ILR, an implantable or insertable loop recorder in an AF population? I use it in studies, and I use it in some patients where there is AF that I know. However, something adding on the AF, plus. So AF plus some unclear symptoms, you don't know what. Some unclear burden, you don't know, is this patient in paroxysmal or in chronic AF? And this might influence the strategy for ablation. Has this patient flutter, atrial flutter, or bradycardia? Is there a syncope, pre-syncope history? Are you thinking about implanting a pacemaker maybe, because this might be useful? Is there any HF, any heart failure in this patient? Or TIA stroke of unclear, undetermined etiology? I will skip that. So they conclude in their paper, Michele and Panos in Europace 2009, that one of the goals for the next future will be to reduce the device size and the weight. That would simplify the implant procedure, and I will show that it is now going on and the future has started. And this would increase the patient and physician's acceptance. Device miniaturization, that's the point, could increase the use of cardiac monitors, which would become the new standard of care for serious adverse event prevention, might be some ventricular, potentially life-threatening arrhythmias, and of course long-term monitoring in patients, especially with atrial fibrillation and other chronic cardiac diseases. But now the future has started. We are now in 2014, 5 years later. We have a new device. The new device is the Reveal Link. And I'm the PI of this study, so I was one of the first guys ever implanting or inserting such a system. I even got a gift for Christmas because I had the first in the world, the first woman in the world that was inserted with this device. The Reveal Link is the next generation Reveal. It's implantable, it's patient and automatically activated, it's long-term, 3 years, for recording subcutaneous ECG. It's miniaturized and has the same indications, but new tools, some new additional tools. So how does it look like? It is very small. You will see it in the Medtronic booth. And I did an insertion on the Medtronic booth, and I completely lost the system in this basis for insertion, so I couldn't find it any longer. It's just so small. But I could get it again. The Reveal Link is 2 grams, you will see it. You have new devices for incision and insertion. It's a very small channel you create. It's no surgery any longer. It's no opening a wound, preparing anything. It's like a vaccination. You vaccinate the system. That's it. Then you have the patient assistant, the CareLink monitor for wireless telemetry, and the programmer and the CareLink printout. So this new device, which has a longevity, I'm sorry for the patients, for the persons in the back not seeing these details. The longevity of the system compared to the previous one is 3 years again. It has around 4 centimeters, but the volume is decreased by 85%. So from 9 cc to 1.2 cc, and from 15 gram to 2 gram. If you hold it in your hand, you can't feel it. It's so light, 2 gram. It has an episode storage of 57 minutes, even longer, and has a cardiac compass and other things. And in addition, there is a new algorithm for detection of AF. So it has 2 algorithms going on and working in the same time. A P-wave detection algorithm along with an RR interval detection algorithm. That makes it very, very, very smart. How you do it? Well, you look at the thorax, you don't have to measure anything. It's simple. Even a surgeon could do it. We say in Austria, it's a joke. It's a joke. We identify the recommended implant location. We have the implant device using the provided implant tools. Interrogate the device to assess R-wave amplitude, closed incision, and acquire an X-ray image that lasts around 5 to 7 minutes. That's all. So you can do it in between your first and second course of the lunch. No problem. It's the 4th intercostal space, it's 1 or 2 centimeters away from the sternum, and it goes in the direction of the axis of the heart. And this is the way we do it. So, as you see, you can pinch the skin and make an incision here, and then pinch the skin and insert the supplied insertion tool completely to create a tunnel. Then you rotate the insertion tool to 180 degrees, and then you insert this pre-mounted device and take back the insertion tool. I think I will end up with the study results because we have some lag in time now. For the Reveal Link study, we had the purpose to assess the usability of this Reveal Link system by assessment of sensing of this device, surface ECG sensing. It has no leads in the heart, of course, it's subcutaneous, and data transmission, wireless data transmission. And the scope was a prospective multi-center global pre-market study with 150 subjects around the world. Phase 1 is now finished, it's 30 subjects. Phase 2 is going on, 120 further. And in phase 1, we have data now on 30 patients, most of them implanted because of syncopal reasons or suspected arrhythmia, or even before an ablation of AF was scheduled, and then look for the result of AF ablation. And here is the first 5 centers in the world having done that on September 27, 2013, and that's me, and that's my co-worker and some staff of the team. In Austria, there's another team in Austria. This is Professor Sanders, Prash Sanders in Australia, and there is 2 centers in the Netherlands. The results, there were 30 patients, most of them 63% female, age 55, with syncope, as I told you, and some suspected AF or AF ablations management. The implant success is 100%. The R-wave amplitude, which has to be more than 0.2 millivolt in the programmer, was reached in every case. The recommended location, 100%. Best location, 93%. And the incision was superior to the inferior of the device in 73%, mostly done in the cath lab. So you don't need any surgery room for that. There was no major migration because you're just having a channel. You just have vaccinating this thing. It doesn't move. There is no artifacts, nothing in the first month. You can forget about that. And because of this P-wave algorithm, I can tell you, I've seen in the first 15 patients only 1 false positive episode. 1. Not more. No major migration, no major procedure-related or system-related adverse events. What has to be improved, where there is more room for improvement now, is the success rate for the wireless transmission. That is only 70%. It can be increased. And this has also resulted already in some system improvement expected to improve this overall transmission. The insertion procedure according to physician procedure survey was very easy or easy in most of the patients, and the incision tool was somehow to be improved, but I think the system is quite perfect if you have some experience on that. So as a conclusion, the new insertion procedure and miniaturized Reveal Link ICM system, including sensing and monitoring, performed successfully. And just for the end of my talk, I'm in time, this is me, and this is the patient, and this is the system. You don't see it. You just take 2 Steri strips to close the wound, that's all, and you vaccinate that. Nothing more than this. 5 minutes. And this is on the X-ray. And it works nice. Thank you.